Hello, everyone. I'm Dr. Juan Andino, and I'm here with one of our sexperts today. I'm from UCLA, do both sexual medicine and male infertility. And tell us a little bit about yourself.
Hi, I'm David Barham. I'm a urologist focusing on men's health in San Antonio. It's a pleasure to be here. Thanks for having me.
Yeah, thanks, Dr. Barham, for being here. Today, we're going to talk about ED, erectile dysfunction. And because we're going to have different folks tuning in and listening to this, both physicians, providers, and patients, let's start very, very generally. Tell us a little bit about, ED. How do you define it? And how do you explain this condition to your patients?
Yeah, that's a great question. Very simply, erectile dysfunction is just the inability to get and keep an erection long enough for satisfactory sexual activity, and what that means and looks like for different people can vary. And so, try to have a individual approach with every patient. But just simply put, the inability to get and keep an erection.
That's exactly right. That's how I always talk about it with folks also. And satisfactory is a key word in there because, what level of sexual activity, penetrative sex, etc., is going to vary patient to patient, couple by couple, etc. When a patient first comes into your practice with ED, what are some of the things that you're asking in their history or medical issues that you see associated with erectile dysfunction?
Yeah, one of the things that we know is really associated with erectile dysfunction is cardiovascular disease. So certainly anything kind of around that realm, any history of cardiovascular risk factors, family history of cardiovascular disease. Um, but there's a lot of other things, history of prostate cancer treatment. But if you're seeing a younger patient, try to find out if they have any physiologic issues. There's a huge psychological component to erectile function, and so just trying to take a well balanced history and try to get at any core um, any core issues that could be causing it, because there's a lot of different factors. Ultimately, the way we treat it is pretty similar among all of the things, but certainly if they have underlying cardiovascular risk factor, counseling will make sure they're getting checked out, because sometimes that's the first sign that there's a cardiovascular problem, and making sure that they're not neglecting that.
And I think that ties in perfectly to the next question I had in mind is, for you, what are some of the first line treatments? And I heard a little bit of lifestyle modification, but medication wise, what are some of the first things that are available for patients?
It's easy to overlook the lifestyle modifications, but I think it's important to talk to all patients about that. And certainly that's something that you can do in conjunction with medications or other treatment. For medications, Viagra, Cialis, and other deep inhibitors have been on the market for a while, and that's kind of the first place to start. Um, as far as preference, it may be what your insurance will pay for, what's on formulary at your institution, but they all work very similarly with some small nuances, and that's usually the first place that I start medication as.
Love your comments on, there's been a huge rise in direct to consumer online pharmacies, etc. I mean, I can't watch a TV show on a streaming platform without getting some sort of ad for for ordering something to just come straight to my house. How do you talk to patients about that? And in terms of safety versus evaluation, do you think that there's an opportunity there for some of these patients where it may be worthwhile to see a specialist?
I think it's definitely raising awareness for patients, and so hopefully that's allowing more patients to come and talk to it about their physician, or talk to it with their physicians. Um, the direct to consumer thing is challenging. What I tell most patients is they're not offering anything that we can't hear in the office. Um, I think patients do have to be careful, because these companies, some of them, a lot of times it's not the cheapest way for them to get the medication, and a lot of times we have navigated this system with other patients, and so it could help them understand what the best financial options are for them. And so I just try to have an open conversation with them. If they have, there's always something new, and it feels like my patients are also always teaching me what the newest thing is on the market or being advertised. But just being open and honest with them and giving them my opinion, and listening to them, and trying to find the best option for them. But typically, what I find is Viagra, Cialis, either through insurance or through direct to consumer pharmacies, are usually the best route to go.
I always focus on that point as well, as I'm meeting patients who've been on some sort of delivery subscription program. And I say, look, we can get you something very similar now that you're actually here and we're having this conversation. We're going to make sure that there's no other comorbid issues, undiagnosed diabetes, etc. but now we can help you either, cost plus drugs, GoodRx coupon, whatever. There's many different ways, sometimes even local compounding pharmacies that can help with the access to medications. And now let's say you're getting someone with a little bit more moderate or severe erectile dysfunction. Perhaps they either fail medications, having bothersome side effects, or they have contraindications. They take nitroglycerin, they take nitrates. What are some of your kind of next steps in counseling and the other options that patients have?
When I first meet somebody with that we're gonna be treating their erectile dysfunction, I give them all the options up front just to kind of introduce them, let them know that there's a lot of different options out there. That way, that you don't start them on a medication and it doesn't work, and then they never come back because they think that's all you have. So from the very beginning, I counsel them on all the options. But almost always, patients prefer to try oral medications first. When that's not working, one of the kind of tried and true things is intracavernosal injections, which is simply just a medication that you're injecting directly into the penis, and a lot of times patients are very apprehensive about it. But I've found that it's usually just kind of the unknown, and that's more of a problem there. Yeah,
Your initial,
and I'll do trial injections in the clinic, teach patients how to use them, and do a formal counseling before they start it. And almost always the patients are like, "It's not at all what I thought it was going to be." And it's a very good way to get kind of reliable physiologic erections. Um, and there's different formulations depending on insurance. There's things that can be compounded, and so there's a lot of variability in there to try to find the right mix for patients that work for them. There's also surgery for penile implants, and a couple different options as far as the type of penile implants that can be great options if patients are really just apprehensive about injection therapy. And then there's other things that are still maybe more investigational or haven't quite made it into kind of our standard guidelines, like shockwave therapy and PRP, which I'm sure we'll talk about in a little bit.
yeah, no, that was a perfect segue. That's before we talk about surgery in a little bit more detail as we start to wrap things up. I would love your kind of 2 cents on shockwave therapy. There's definitely been a growth in the data supporting its use of shockwave therapy, but coverage is still a big issue. PRP has been out there for a while, certainly in other specialties. I feel like 5 years ago it held a lot of promise, and now it seems like the data is not necessarily flushing out as well as people were hoping. So yeah, actually on those two, let's get a little bit more detail.
Yeah, I think you summed it up pretty well. I think the data is definitely a little more promising for shockwave therapy. There's still a lot of unknowns with shockwave therapy. There's a lot of limitations as far as it not being covered by insurances, and it can be costly. Just particularly in my practice, it's not something that I've integrated just because of the workflow, the logistics, and the cost. It doesn't kind of work in my practice. But I think it's a pretty safe, and I think that has been pretty well demonstrated in the literature that it is safe. We're trying to learn kind of the right, for lack of a better term, the right kind of dose and regimen for it. And that will be, hopefully teased out better, but there's a lot of promise there as a kind of restorative therapy. PRP, you kind of hit it the nail on the head. Like originally there was a lot of promise. It seems to be fading off more. And again, it's not something that I offer. But patients should know about it. And there's a lot of clinics that may target that directly, and so it's important for patients to understand the limitations that it has, so that they're making sure they're selecting the right choice.
Yeah, no, that's a fantastic point. And then lastly, before we talk a little bit about penile implant in more detail, tell us some about Doroxon. It's this new medication available in the U.S. market. Have you talked to patients about it? Have you had patients come in saying that it's over the counter, that they've been getting it, using it? Share a little bit of the data around the Doroxon.
Yeah, there's a lot of excitement amongst the Roxon, especially for patients because they don't have to get a prescription, and so I think a lot of our patients are maybe using this or have used this, and we don't realize it unless we ask about it. It's actually been approved by the FDA as a medical device since 2023, so for a couple years already now. But it was approved as a medical device, non-medicated. It's a gel that has alcohol and water, which are volatile components. So when it gets applied to the head of penis, those things evaporate, which causes cooling and then a rewarming effect. And it's thought that helps stimulate the nerves, leading to erection. Um, there is clinical benefit in the data that was submitted to the FDA for approval. It's probably most helpful in patients with more mild forms of erectile dysfunction, but has a very safe side effect profile. It's not a medication. And so, really, the only side effect that was reported is just some irritation at the site that it was applied, which is not surprising, but really only occurred in a couple% of patients. And so, I think it's really safe, and is a great option. So that shows something as providers that we should be asking about. So I'm sure patients are using their going to ask.
Yeah, that's great. And then lastly, you mentioned earlier, and it's part of our, AUA guidelines that penile prosthesis, penile implant surgery is an important part of the treatment paradigm. There's going to be some folks who fail medications who, over time, the severity of ED gets worse, and so they become candidates. But are there certain patient populations that you've seen that are either more likely to need an implant or more likely to benefit from it?
The penile implant is a great option for anybody who wants reliable rigidity. Typically, it's people who have already tried medications and that's not been effective, just because that's such a less invasive option. But there's certain requirement that you have to fail every option that's out there. And some people prefer to get to that sooner. And it does a great job of providing rigidity. Certainly, if you're talking about an inflatable implant, that's a mechanical device, so patients have to have the dexterity to be able to use it, although there's a malleable implant that's simpler if their dexterity is not as good. As far as patients who may be, more likely to require it, certainly those with more severe forms of erectile dysfunction that are very, less likely to respond to medications or injections. So people after prostate cancer surgery, patients who have had priapism, which is prolonged erection that's lasted for usually a couple days, the chance of any return to of erectile function is pretty low. So certainly those with more severe erectile dysfunction, more likely to need it. But really, anybody who wants good, reliable erections, they can be a great option.
Thank you for your time today. This was super insightful, very nice overview of ED treatment options and what's kind of new and exciting, but the data is still, to be determined whether it gets incorporated into our general treatment paradigm. Let me give you a little bit of and you literally have a microphone, but a megaphone. If you had a final kind of concluding thought or a PSA for our audience, is there anything in this kind of realm of erectile dysfunction that even if someone hasn't made it to your clinic or to mine, that they should know about?
Yeah, I think the most important thing for patients to know is this is common. We deal with it every day. There's no reason to feel shame or embarrassed by it. We have these conversations with patients every day. There's so much that we can do to restore erectile function, and it can have such a significant impact on a patient's quality of life. So um, come see us. Come see us, and we can help you.
Come see us. I love it. I think that's a perfect place to end. Thank you for your time.
Thank you.